Hello there, welcome to part 2 of this series on clinical negligence. My name is Clifford from Clifford Odhiambo and Company Advocates. We are located at Jumia Place along Lenana Road in Kilimani. Last week in part 1 of this series, we analyzed a recent decision of the High Court of Kenya in the case of Joyce Mwonjiru Njuguna versus Maurice Wambani Another Health Services. In that particular case, the court found the defendants jointly and severally liable for negligence and proceeded to award the estate of the deceased Kenya shillings 4.5 million for the unnecessary surgery together with the pain and suffering that the deceased underwent. Because the court did not exhaustively analyze the issue of negligence, you may be watching this and questioning what is therefore negligence. Well, in general terms, negligence may be described as failure to exercise care when the circumstances demand. What amounts to negligence is dependent on the circumstances of each particular case. It may consist failure to do something that ought to be done, or not doing it at all, or doing it differently. To understand what specifically amounts to clinical negligence, we travel back in time to 1957 to revisit an Old English case cited as Bolam versus Fiera Hospital Management Committee. From the case, we learn that the plaintiff was admitted at the defendant hospital with a mental illness of a depressive type. He was examined by a consultant psychiatrist who advised the plaintiff to undergo electroconvulsive therapy. The plaintiff signed a consent form before undergoing the treatment. However, the doctor did not warn him that he was going to experience violent bouts of convulsion of a fit in nature. From the case, we also learned that the plaintiff was not administered relaxant drugs before or while undergoing the treatment, and as fate will have it, he suffered from violent bouts of convulsion and in the process suffered severe injuries, which consisted the fracture of his pelvic on both sides and dislocation of both his hip joints. The plaintiff sued the hospital and argued that the defendant was negligent in failing to warn him of the risks associated with the electroconvulsive therapy. He argued that had he been warned, then he would have had an opportunity to elect whether or not to undergo the treatment. Secondly, the plaintiff argued that the defendant was negligent for failing to use relaxant drugs, which, had they been used for all intent and purposes, they would have minimized the risks associated with the violent convulsion. Lastly, the plaintiff argued that in the event that the hospital was not going to use the relaxant drug, at least some form of manual control ought to have been used. This case is particularly important because Lord McNair distills what constitutes medical negligence by stating that in the realm of diagnosis and treatment, there's ample scope of difference of opinion, and one is not guilty of negligence merely because their conclusion differs from that of other professional men. Neither is one guilty of negligence because they have demonstrated less skills or knowledge as others will have shown. Lord McNair further states that a doctor is not guilty of negligence if he has acted in accordance with a practice accepted as proper by a responsible body of medical men skilled in that particular art, or merely because there's a body of opinion that takes a contrary view. Lord McNair proceeded to make a passionate defense for doctors by stating that courts will be doing a great disservice to the community at large if they were to impose liability on hospitals and doctors for everything that goes wrong. Doctors will be led to think more of their safety than the good of their patients. Initiative will be stifled and confidence will be shaken. That a good sense of proportionality requires that courts should have due regard of the conditions under which hospitals and doctors operate in. That while courts must insist on proper care of the patients at every stage, they must not be quick to condemn as negligence that which is only a misadventure. In essence, the Bolam case states that a doctor who is accused of negligence only has to demonstrate that other doctors will have acted the same way while offering care to a patient. Differently put, even if a doctor has made a mistake, so long as he has not been declared guilty of negligence by a responsible body of doctors who through the expert witnesses can vouch that they too will have made the same mistake under the same circumstances, then he or she is not guilty of negligence. But does this mean that a doctor or a hospital should not warn a patient of the risks associated with the treatment or a surgery beforehand? Well, this question ushers us to the next topic on disclosure. In the Bolam case, the doctor argued that there are some disadvantage in emphasizing any danger to a patient, however minimal it is, because there's a risk of a patient refusing treatment by declining a remedy that may be only available to him. He further argued that once an operation has been decided upon, a patient should be properly prepared. However, he should not be informed of the risks involved or the risk of catastrophe. Despite the misgivings in this particular case, this remained the law until sometime in 2015 when the UK Supreme Court in the case of Montgomery versus Lanarkshire Board had the opportunity to interrogate the long-standing principles espoused in the Bolam case. The brief facts of the case are that Ms. Montgomery studied molecular biology at Glasgow University. She graduated with a BSc and worked for a pharmaceutical company. The court describes her as a highly intelligent person. Her mother and sister are both practicing medical practitioners. Sometime in October 1999, she gave birth at the defendant hospital. But due to complications during the delivery, she gave birth to a child with severe disabilities. She sued the hospital for the injuries her baby sustained, which she attributed to the negligence of the consultant gynecologist and obstetrician, who were responsible for her care during her pregnancy and labor. She contended that she ought to have been given advice about the risks associated with shoulder dystocia before proceeding with vaginal delivery. Shoulder dystocia is the inability of a baby's shoulder to pass through the pelvis. In the case, she is described as being a person of a smaller stature and suffering from insulin-dependent diabetes mellitus. Women suffering from diabetes are likely to have babies that are larger than normal, with the concentration of the weight being around the shoulders. Physical maneuvers and manipulations required to free the baby may cause it to have broken shoulders or sometimes damage to the nerve roots connecting the arm to the spinal cord. Sometimes, as was in the present case, this may result into permanent disability. One of the accused doctors in the case accepted that her condition carried risks, but stated that it was not in her practice to spend a lot of time, if any at all, discussing the risks of shoulder dystocia with her patients. This was because, in her estimate, the risks were very minimal, and the moment she mentioned the risks, most women would elect to have cesarean section, whereas it was not in the maternal interest of women to have cesarean section. The court held that it would be a mistake to view patients as uninformed, incapable of understanding medical matters, or wholly dependent on information from doctors. Societal and legal changes point towards an approach in law that treats patients as informed adults capable of understanding that medical treatment is uncertain of success and may involve risks, that patients are able to carry on the responsibility of the risks that involve their lives, and that are able to live the consequences of their choices. This carries with it the responsibility on doctors to inform their patients of the inherent risks involving their treatment. That an adult of sound mind is entitled to decide which of the available medical treatment he should undergo, and their consent must be obtained before a treatment affecting their bodily integrity is undertaken. This imposes an obligation on doctors to ensure that their patients are informed of all material risks involved in a proposed treatment and offer reasonable alternatives. A risk is material if a reasonable person in the patient's position will attach significance to it, or if the doctor knows that the patient will attach significance to it. Building from the above cases, it is evident that medical practitioners and hospitals owe their patients a duty of care. If a doctor holds himself out as possessing specialized knowledge and skills, and is consulted by a patient on account of possessing such specialized knowledge and skills, then he owes a duty to that patient to at all material times demonstrate diligence, care, knowledge, caution in administering treatment to the patient. In summary, for one to be successful in a complaint against a medical practitioner or a hospital, one has to demonstrate that the hospital or medical practitioner owed them a duty of care, and how they were in breach of this particular duty, and as a result, what harm or injury they suffered. Well, that's it for now. Be on the lookout of part 3 of this segment, in which we'll be concluding our series on medical negligence by looking at how does one institute a complaint against a medical practitioner or a hospital. For now, bye-bye.